You know, usually when you step into an operating theater for reconstructive surgery, there's there's this baseline expectation of anatomical precision.
Right.
It's
Right.
almost like mechanical engineering. You have a trauma patient with a laceration or, a crush injury, and the anatomy shows you exactly what is severed.
Exactly.
And as a surgeon, you can just point your forceps and say, there it is, there's the margin. That is the exact boundary of what needs fixing.
Yeah. I mean, the damage is generally visible and, well, quantifiable. You map the defect, you debride the obviously necrotic tissue, and the boundaries of the injury are usually quite clear to the naked eye. The
Hmm.
pathology is just right there in front of you.
But then a patient rolls into the trauma bay following an electrical injury, and suddenly that whole predictable surgical landscape is just completely upended.
Oh, totally. It's a nightmare.
You might be looking at a tiny, innocuous, almost a trivial puncture wound on the skin, but underneath,
Yeah.
in the deep fascia and the muscle bellies, it is absolute chaos.
Complete chaos. Yeah.
So, welcome to this revision deep dive. Our mission today is highly specific. This is a targeted, high-yield Q&A session on electrical and lightning injury mechanisms, custom-tailored for your plastic surgery board exams, like the FRCS.
Right.
No fluff, just the facts, the physics, and the pathophysiology you absolutely need to know.
It really is the absolute definition of diagnostic muddy waters.
Mm-hmm.
And because the true extent of the injury is, hidden from the surface, the board examiners absolutely love to test your understanding of the underlying mechanism.
Oh, they love it.
Because, I mean, you cannot treat what you do not understand.
Exactly. Now, before we jump into the physics of our first question, take a quick second to hit the follow button on your app so you never miss one of these revision sessions. And if you learned something valuable for your exams today, please leave us a rating.
Highly recommend it.
Also, for those of you serious about dominating the boards, make sure to grab a premium subscription to the show to unlock exclusive access to our Journal Club and Clinical Cases deep dives. Okay, let's dive right in. To kick things off, let's look at the foundational physics. Because as a plastic surgeon, you simply cannot understand the resulting tissue defect without understanding the current that created it in the first place.
Right.
So let's ground this in Ohm's law and how it applies to a real-world household exposure.
Yeah, let's start with the mathematical relationship. You really have to keep front and center in your mind. You already know Ohm's law, right? Voltage equals current times resistance, or V equals IR.
Yeah.
But for the FRCS, you need to memorize the standard denominator for the human body. The baseline average resistance of the human body is tested as 500 ohms.
Okay, so if we take that 500 ohms of resistance and apply it to a standard household exposure, the output is going to differ depending on your geographic location.
Exactly.
In the UK, the mains operate at 230 volts. So 230 volts divided by 500 ohms means the current driven through the patient is 0.46 amps.
Precisely. And if we look at the United States, where the mains operate at 120 volts, you divide that by the 500 ohm resistance, giving you an exposure of 0.24 amps.
Right. Now let's unpack those numbers because intuitively, 0.46 amps or 0.24 amps sounds, well, incredibly small.
It does.
We're talking about fractions of a single amp. So does that mean these low voltage household shocks are actually safe?
No, absolutely not. That is a very common and very dangerous misconception. What's crucial to understand here is the threshold of the human myocardium.
Okay.
The human heart doesn't require some massive power surge to be thrown into a fatal arrhythmia. Ventricular fibrillation, or VF, can be triggered by a shock of just 1 amp.
Oh, wow. So those fractions of an amp you get from like dropping a plugged-in appliance or touching a live wire in the kitchen,
Yeah.
they are sitting dangerously close to that lethal threshold.
Exactly. They are well within the margin of error to be fatal. This is why you must know the classifications for the boards.
Right.
Low voltage is strictly defined as anything under 1,000 volts. High voltage is greater than 1,000 volts. And then there's the extremely high voltage category, which is, exclusively reserved for lightning strikes.
But going back to that low voltage category, the under 1,000 volts, even though the voltage is technically low compared to, say, industrial power lines, the cardiac threat is still massive.
Yes, low voltage can and absolutely does cause cardiac arrest and death. The clinical trick here, and what the boards want you to recognize, is that low voltage injuries typically cause very little actual tissue destruction.
Right, because there's just not enough energy for that.
Exactly. Because there isn't enough energy to cause massive deep tissue coagulation, they're usually managed conservatively from a purely surgical standpoint.
So the primary threat is cardiopulmonary, not reconstructive. But what is the protocol if a patient presents after a low voltage shock and they seem, absolutely fine?
Right, so if the patient comes in, you get a 12-lead ECG, and if that initial ECG is completely normal after a low voltage injury, further cardiac monitoring is not required.
Okay.
You do not need to admit them to a telemetry bed purely for monitoring if that first ECG is clean and they're entirely asymptomatic.
Got it. Okay, so we've established that household mains, even at low voltage and low amperage, can be lethal, but we need to distinguish between the types of current delivery because it completely changes the clinical presentation.
It really does.
Why is alternating current, or AC, considered 3 times more dangerous than direct current, DC, for a given voltage?
Well, this comes down to exactly how human muscle physiology responds to the specific frequency of the alternating current. AC doesn't just push energy continuously in one direction. It oscillates back and forth.
Right.
And this oscillation causes continuous muscle tetany, that state of sustained involuntary muscle contraction where the muscle fibers simply cannot relax.
Let's dig into the why of that tetany, because I think that's what makes it so dangerous. Normal muscle contraction relies on a cycle of depolarization and repolarization.
Exactly.
But physiological tetany locks that cycle up specifically when the frequency of the external alternating current is between 40 and 110 hertz.
That is exactly the mechanism. At 40 to 110 hertz, the electrical current is oscillating faster than the muscle's natural repolarization and relaxation phase.
Wow.
So the muscle receives the next electrical signal to contract before it has any physiological opportunity to let go from the previous signal. It is mechanically jammed in the contracted state.
And where do our household power grids sit on that frequency spectrum?
Right, dead center in the maximum danger zone. Mains electricity is supplied at 50 hertz in the United Kingdom and 60 hertz in the United States.
Unbelievable. So the current is oscillating at the exact perfect frequency to maximize sustained, unbreakable muscle contraction?
Yeah, unfortunately.
What does that actually mean for the patient gripping a live wire?
It means the victim is physically, biomechanically prevented from releasing the electrical source. Their flexor muscles in the hand and forearm, which are naturally stronger than their extensors,
Right.
they just lock down hard on the wire or the appliance. They simply cannot let go, no matter how much they want to. This let-go threshold is surpassed, dramatically increasing the duration of the contact.
And obviously, longer contact duration pumps exponentially more thermal energy into the body, leading to far worse burns.
Exactly. And not to mention what that specific frequency does to the heart.
Right.
High-frequency alternating current makes ventricular fibrillation significantly more common. The myocardium is highly sensitive to that continuous alternating rhythm, which readily overrides the sinoatrial node.
Okay, so if AC locks you in and cooks you, how does that compare to the classic direct current or DC presentation? If I touch a high voltage DC line, say a battery bank or certain industrial rails, what is the mechanism of injury there?
Well, direct current flows in one continuous direction. It does not alternate. Because it doesn't have that rapidly oscillating frequency, it doesn't trap the muscle in tetany.
Okay.
Instead, DC tends to cause a single, massive, violent muscle spasm.
And rather than locking the victim to the source, that violent instantaneous spasm often acts like an explosion, basically throwing the body completely away from the electrical source.
Precisely. The flexors and extensors all fire at once, and the sheer biomechanical force throws the patient across the room. So the contact time is instantly cut short.
Wow.
Because they are thrown, the primary injury pattern with DC is often blunt trauma. When a DC patient rolls in, you are secondary surveying for injuries from the fall, like cervical spine fractures, long bone dislocations, traumatic brain injury.
Rather than the prolonged, deep thermal burns you typically see with an AC grip.
Right, exactly.
But we can't ignore the heart with DC either, right? Even with a split-second contact, does DC still carry a significant cardiac risk?
Oh, it absolutely does. Arrhythmias can certainly arise from a DC shock, but typically it requires the shock to be delivered during a specific, vulnerable phase of the cardiac cycle. Think of the R-on-T phenomena.
Oh, right.
The DAC impulse has to hit at just the wrong microsecond of the repolarization phase to throw the heart into chaos, whereas AC just overwhelms the whole cycle continuously. But make no mistake, DC can instantly stop the heart.
Okay, having covered how current either traps a patient in a death grip or throws them like a rag doll, let's explore what actually happens when that electrical energy penetrates the tissues in high voltage scenarios, meaning anything greater than 1000 volts.
Yeah.
In these high voltage injuries, the severity of the tissue destruction is proportional to the current, the resistance of the tissue, and the duration of contact. So how does this specific resistance of different human tissues dictate the surgical picture we see in the trauma bay?
This is a really foundational concept for the FRCS. Current is determined by voltage and resistance, but the resistance inside the body is entirely dictated by the anatomical pathway the current takes.
Right.
Different tissues have vastly different levels of resistance, largely based on their water and electrolyte content. And this is the golden rule. More electrical resistance means more thermal energy, or heat, is generated as the current fights its way through that specific tissue.
Let's break down that hierarchy of tissue resistance. Why do some tissues conduct beautifully while others turn into, basically, space heaters?
We group them into three main categories. First, you have low-resistance tissues. These conduct electricity very easily because they have high water and electrolyte concentrations.
Okay.
This group includes nerves, muscles, and blood vessels. They offer very little pushback to the current.
Then on the opposite end, you have high-resistance tissues.
Right. High-resistance tissues have very low water content.
Okay.
They oppose the current strongly. This category includes bone, fat, and tendons.
And what about the skin? Because clinically, that's the primary barrier. That's what we see when we first examine the patient.
Skin sits right in the middle. It has intermediate resistance. But the crucial clinical point is that skin is dynamic. Its resistance is highly variable based on its physiological condition.
Like sweating.
Exactly. If the skin is sweating, that moisture and salt drastically lower its resistance, making it much more conductive. Conversely, if a patient has thick, heavy calluses like a manual laborer might have on their palms or soles, that thick stratum corneum massively increases the skin's resistance.
But here's the frightening part about skin resistance during an electrical shock. What happens to the skin when the contact is prolonged?
Well, prolonged contact generates surface heat, which causes the skin to blister. And that blistering is devastating to the patient's survival because the fluid in the blister functionally decreases the skin's electrical resistance to near zero.
Wow.
It completely destroys the protective barrier. This sudden, catastrophic drop in resistance allows the built-up current to suddenly surge deep into the underlying tissues, causing extensive, deep destruction.
Let's visualize that deep destruction, because I think this analogy perfectly captures what you will see as a surgeon. Because bone is in that high resistance category, it fights the current, and therefore it generates the most thermal energy.
Yes.
It acts almost like the heating element in an oven. The bone gets incredibly hot, and it literally cooks the surrounding low resistance muscle from the inside out.
That oven effect is a fantastic way to picture it, and it perfectly explains the trap that catches so many surgical trainees. Because the current is highly concentrated at the points of contact with the electrical source and the point of grounding, it causes distinct entry and exit wounds.
Right, which you're looking for.
Yes, you must always seek these out during your primary survey.
But those surface wounds are notoriously deceiving. You might look at a patient and see what appears to be an entirely trivial cutaneous wound, maybe just a small dime-sized charred area on the palm and a similar mark on the sole of the foot.
Incredibly deceiving. Those trivial, superficial wounds hide massive, extensive, deep tissue damage. Because of that oven effect you just described, the heat generated within the high-resistance bones radiates outward, coagulating and burning the adjacent low-resistance muscle from deep within the limb.
Jeez.
You have a patient with intact skin, but their deep flexor compartment is entirely necrotic.
So what are the immediate limb-threatening clinical consequences of that internal muscle destruction?
The most pressing consequence is acute compartment syndrome. As that deep, cooked muscle undergoes necrosis, it rapidly swells within the unyielding fascial compartments.
Right.
The tissue pressure rises exponentially, cutting off capillary perfusion and venous return. It is incredibly common in high-voltage injuries, which is why your threshold for surgical intervention must be so low.
And beyond the physical swelling, what is the systemic biochemical marker that screams to us that this deep muscle necrosis is actively happening?
You must look for myoglobinuria. As the muscle cells die and physically break down, they release massive amounts of myoglobin.
The oxygen-binding protein.
Right, exactly. They release it directly into the bloodstream. This myoglobin is then filtered by the kidneys, turning the urine a dark, muddy tea color.
Wow.
If you place a catheter and see dark tea-colored urine, It is a massive red flag indicating profound underlying muscle necrosis, and it puts the patient at immediate risk for acute kidney injury.
Okay, so we know the local tissue effects and the systemic fallout, but you mentioned earlier that the current pathway determines the resistance. For the board exams, does the specific anatomical path the current takes dictate other predictable specific injuries?
Absolutely. The anatomical route is highly predictive of the complications you need to anticipate. If the pathway of the current passes through the chest, say from an arm to an opposite leg,
Right.
you must anticipate myocardial problems. The heart is directly in the crossfire of the electrical field.
What if the current travels through the brain? Say, an entry wound on the scalp and an exit on the foot.
If the pathway goes through the cranium, the primary acute complications are respiratory arrest and seizures. The massive electrical impulse completely short-circuits the central nervous system's regulatory centers in the brainstem, turning off the physiological drive to breathe.
And there's a very specific, often delayed, sensory complication if the current passes through the face, right?
Yes, this is a classic FRCS board question. If the current passes through the orbits, the patient is at a very high risk of developing bilateral cataracts.
Wow, really?
Yeah, the electrical energy directly damages the proteins in the lens. This can develop weeks or even months after the initial injury, so these patients require long-term ophthalmology follow-up.
Okay, so we've firmly established that thermal heating, the oven effect radiating from the bone, destroys tissue. But here's where the pathophysiology gets truly fascinating.
Oh, yeah.
Sometimes, as plastic surgeons, we open up a fascial compartment to do a fasciotomy, and we see massive, widespread cell death. But there are absolutely no signs of thermal burns, no charring, no coagulation, no signs of heat damage whatsoever. What is the exact cellular mechanism that causes this profound muscle necrosis when there is absolutely no thermal energy involved?
You are talking about electroporation. This is a suggested, entirely non-thermal mechanism of cellular injury, uniquely associated with high-voltage exposures. It explains why we see cell death far away from the bone.
Wait, how does an electrical field destroy a cell without heating it up?
It comes down to the biophysics of the cell membrane. Electricity, when the voltage is sufficiently high, causes a direct physical change in the protein and lipid configuration of the cell membranes.
Okay.
The intense electrical field physically distorts the cell wall, pulling it apart and essentially punching microscopic holes or pores right into the membrane structure.
Hence the name electroporation. You are using electricity to create pores.
Exactly. And once those pores are formed, the cell membrane loses its most critical function, which is selective permeability.
Oh, wow.
You suddenly get the free, totally unregulated passage of water, sodium and calcium rushing into the cell, and potassium rushing out. The cell instantly loses its osmotic balance. It swells, it lyses, and it dies.
Without any heat.
Without a single degree of thermal temperature rise. This mechanism causes widespread muscle necrosis. The cells are essentially drowned and ripped apart by their own loss of boundary.
It's terrifying how efficient that is at a microscopic level.
Truly.
All right, moving on from manufactured high voltage, let's tackle our final category. For the boards, you must also be able to classify the mechanisms of lightning strikes.
Right.
Lightning is an entirely different beast. It is neither AC nor DC. It is a massive, instantaneous, unidirectional current impulse involving tens of millions of volts. We need to break down the 4 specific mechanisms of lightning injury. The first one is straightforward. A direct strike. The lightning channel connects directly with the individual, and as you might expect, this is usually instantly fatal. But lightning doesn't just vanish when it hits something else first. If I'm standing under a tall tree during a storm, and the tree takes a direct hit, that electrical energy is desperately looking for the quickest path of least resistance to the ground. Because of my water content, am I a better path than the tree trunk?
You absolutely are, which brings us to mechanism number 2, the side flash or splash.
Okay.
The lightning strikes a taller structure first, but because the human body is a superior conductor to wood or air, the current discharges, literally physically jumping through the air from the tree directly to the nearby person.
And what if I'm physically touching a conductive object that gets struck? Say I'm holding a metal golf club or leaning on a wire fence that gets hit 100 yards away.
That is mechanism number 3, a contact injury. You become part of the circuit because you are physically touching part of the current's pathway at the exact moment the lightning strikes the object. The energy travels down the fence and straight into your hands.
Which brings us to the 4th mechanism, and physically, I think this is the most fascinating one because it accounts for a massive number of injuries without the person ever being near the actual strike zone. How does step voltage or ground current actually work?
Well, when lightning strikes the Earth, that immense electrical charge doesn't just stop or instantly neutralize. It spreads radially outward through the ground, like ripples in a pond.
Oh, interesting.
As it spreads, the energy dissipates, creating a gradient. This spreading creates a literal potential difference in voltage across the surface of the ground itself. Step voltage describes the potential difference that occurs between a person's 2 feet.
Because if you are standing with your feet apart in this expanding electrical field, one foot is closer to the strike zone than the other, meaning one foot is at a higher voltage than the other.
Precisely. And remember our rule about resistance. The human body, full of water and electrolytes, is a much better conductor of electricity than the dirt and rock of the Earth.
Yeah.
So when the spreading current encounters that potential difference between your feet, it takes the path of least resistance. It preferentially flows up the leg closest to the strike, travels through your pelvis and torso, and flows down the other leg to continue its path, rather than continuing to push through the highly resistant ground.
Which perfectly explains the classic agricultural tragedy of why herds of large animals are so vulnerable to this specific mechanism.
Yes, cows and horses are frequently killed by step voltage because of their anatomy. Their front and back legs are placed very far apart.
Right, yeah.
That large physical distance creates a massive potential difference across their bodies, much larger than a human stance. This massive voltage difference drives a lethal amount of ground current straight through their vital organs, stopping their hearts instantly, even if the lightning struck the ground dozens of yards away.
Incredible. So bringing this back to our human patients in the trauma bay, what is the classic clinical presentation of a lightning strike survivor? Because based on the sheer, unimaginable millions of volts in a lightning strike, you would intuitively expect massive, catastrophic internal burning and amputation-level injuries.
You would think so, but the clinical reality is completely counterintuitive. Lightning is typically conducted primarily as an external flashover.
Flashover.
Yeah, because the voltage is so high and the impulse is so incredibly fast, often lasting only a few milliseconds, the electrical current flashes over the outside surface of the body, following the sweat and moisture on the skin. This rapid external flashover actually limits internal conduction.
So the energy simply doesn't have the time to penetrate deeply and cook the bones and muscle like a prolonged high-voltage AC wire exposure would.
Exactly.
Yeah.
The duration is simply too short. Because of this flashover effect, severe deep muscle damage, compartment syndrome, and extensive full-thickness thermal burns are actually quite rare in lightning strikes.
Okay, so if they aren't burning from the inside out, what are the primary life-threatening threats we need to manage?
The immediate threats are primarily cardiopulmonary and neurological. Because it is a massive, instantaneous current impulse, a systole, which is a complete flatline cardiac arrest, is incredibly common.
Wow.
You also see immediate respiratory arrest because the medullary respiratory center in the brain is short-circuited. Furthermore, survivors often have severe, acute neurological damage, ranging from ruptured tympanic membranes to prolonged confusion and paralysis. The delicate electrical systems of the body are simply overwhelmed and temporarily or permanently shut down.
And when we do our secondary survey of the skin, is there a specific diagnostic sign we should be looking for that confirms a lightning strike?
Yes, you must meticulously inspect the skin for Lichtenberg figures. These are distinct, fern-like branching erythematous patterns on the skin. They look almost like a red tattoo of a tree branch.
Oh, wow.
If you see them, they are entirely pathognomonic of a lightning injury. Nothing else in medicine causes them. They're essentially a physical manifestation of the electrical discharge tracking along the moisture of the skin.
But as a surgeon, you have to document them immediately because they don't stick around, do they?
No, they do not.
Yeah.
While they are a perfect diagnostic clue for your exams, they are transient. They typically last only a few hours before fading away completely as the superficial capillary dilation resolves.
Okay, let's bring all of this together for your exam preparation and your ward management. Based on everything we've just discussed, here is your rapid-fire checklist of the essential management principles for high-voltage electrical injuries. First, you need continuous cardiac monitoring, at least initially, to watch for those life-threatening arrhythmias triggered by the current. Second, you need aggressive intravenous fluid resuscitation to flush the systemic circulation. Third, you must initiate renal protection protocols to aggressively protect the kidneys from that massive myoglobin load released by the dying muscle. And critically, from a surgical perspective, you need a very, very low threshold for early fasciotomy to decompress those swelling fascial compartments before the muscle completely dies from the oven effect.
If you step back and connect this to the bigger picture, every single one of those clinical management steps is a direct, logical response to the specific pathophysiological mechanisms we just spent this revision session exploring.
Exactly.
You hydrate aggressively for the muscle breakdown, you cut early for the rising compartment pressures, and you monitor strictly for the electroporation and thermal damage to the myocardium. It is all beautifully, tragically connected.
I want to leave you with a final thought to mull over as you continue your revision. We spent a lot of time talking about electroporation, how high voltage punches microscopic holes in cell membranes, causing massive necrosis without heat. Well, think about how medical science evolves. Researchers and oncologists are now reverse engineering that exact mechanism of injury and turning it into a targeted cure.
Yeah, it's fascinating.
It's an emerging field called electrochemotherapy. By applying precise, localized high-voltage pulses to solid tumors, surgeons can intentionally cause electroporation in the cancer cells. This temporarily opens up the tumor cell membranes, allowing chemotherapy drugs to rush in at concentrations hundreds of times higher than normal before the pores seal back up, trapping the poison inside the cancer while sparing the healthy tissue around it. The very mechanism that destroys a limb in an electrical accident is actively being harnessed to destroy tumors.
It's a profound reminder that understanding the exact biophysics of an injury doesn't just help us mitigate trauma, it occasionally hands us the blueprints for the next generation of targeted therapies.
Absolutely. The destructive chaos of today becomes the precision engineering of tomorrow. Please leave a comment or question about today's material on your podcast platform. We really love seeing what parts of the deep dive are helping you the most.
Definitely.
And remember to grab that premium subscription to access the Journal Club and Clinical Cases deep dives to fully prep for your upcoming exams. Keep studying hard, and we'll catch you on the next one.